Basically, my topic is about the gait. It's a very used topic, and we little bit of theoretical discussion on gait. We all know that it's an rhythmic translatory progression of the body with alternative propulsive and retropulsive motion. So, just a quick review of the gait. We all know that gait is basically divided into two phases: stance phase and the swing phase. And we all are aware of this, all the stages of stance phase and swing phases. So, apart from that, there are some variables of the gait. Basically, they are time oriented and distance oriented, which will give you some qualitative information. So, time variables, they are in the form of stance time, or a single leg support or a double support, then some swing time, then stride, cadence, and speed. And in distance variable, it depends on the stride length, step length, and a degree of toe out. This explains all the details of that, but it is beyond our today's scope. And as well as the Sanders has given some determinants of the gait. They are nothing but some adjustment made by the pelvis, hip, and knee, ankle, so as to have a less energy expenditure and thereby improving the more efficient type of a gait. So, what are different types of gait? The list is really exhaustive. Basically, they are divided into a neurological causes and a musculoskeletal causes. And as I have pointed, there are some CNS related or brain related also gait, which is again today we are not considering. We are considering the spine related gait as well as the hip related gait. So, I am not included about the knee and ankle pathologies also. So, this has already been explained by Priyank. The antalgic gait, we all know it's a painful gait. The stance phase is less, and generally the patient keeps the hand over the painful area. So, this is also second very common gait is a Trendelenburg gait, or called as a gluteus medius gait, where the pelvis dips down. The third one is a arthrogenic gait, or another it is called as a stiff hip gait. You can see this patient, he has a bilateral hip, fuse hip. The left side was operated in the form of total hip, the right is still stiff hip. So, in this case, the pelvis is elevated and patient tries to lift the pelvis, or hip hiking what they call, and to clear the toe. This is another common gait called as a waddling gait, or in common words is a myopathic gait or a duck waddling. It is basically, we can see in any bilateral hip pathologies more commonly than that of a spine, but we can get it in some spinal pathologies also. Coming to this typical steep gait or a neuropathic gait where the dorsiflexors are weak or paralyzed. And in very high grade listhesis, when there is a deformity in the L5 S1 area leading to L5 kyphosis and more verticalized L5, and then ultimately the retroversion of the pelvis, which leads to hamstring tightness, and ultimately the patient will have hip flexion, knee flexion, and a sort of a crouch gait called as Phelan-Dixon sign. Again, this is one of the common another reason where the another important stabilizer of the hip, gluteus maximus, is weak. So, then patient will have this posterior lurch gait or a rocking horse gait when the trunk leans posteriorly in a hyperextended hip. And this is a wide base gait, or another it's called as a myelopathy gait, a staggering type of the clumsy gait. Generally, we get in a spondylotic myelopathy type of variety. So, all these are the very commonly seen gait in hip pathology as well as in spine pathology. There are some certain studies also. This is one good article in Journal of Spine Surgery, which analyzes the gait pattern in various degenerative lumbar spine and concludes that there is a decreased gait velocity and cadence in the number of steps per minute, which is also reduced with increased double support stance phase. Again, there is another this good paper which differentiate between the gait characteristics of the patients with lumbar spinal stenosis and OA hip, and in the form of the study, the ultimate conclusion is in this waveform where there is a deep notch, what we found in L4 group. So ultimately, the gait is nothing but a manner or a style of walking which differs from individual to individual. And we all know that walking is, one has to give thorough attention to the how the patient walks in your clinic, and that will lead to the near to our conclusion of the clinical diagnosis. Thank you.